Okay, good morning, and welcome to the Davies Use Case webinar being presented by Mercy Health on flow sheet charging for bedside procedure. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons, and I'm the Manager of Quality and Patient Safety at HIMSS, and it's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress and guidance, progress and information and technology-enabled patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is the pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievements of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Award-winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speaker for today, Jessica again. And Jessica, I'll turn it over to you, and you can introduce yourself.
Sure. Thank you, Arnold. I am Jessica Ginn, and I'm an application coordinator at Mercy Health. In my role, I'm on a team that's responsible for system build and maintenance of the Epic Resolute Hospital Billing application. And today I'm excited to share with you a case study on how our organization leveraged a clinical workflow change in order to increase gross revenue for our bedside procedure charges. So to start, I'm going to provide some background about Mercy Health, the organization I work for. We are a Catholic healthcare ministry serving 7 regions in Ohio and Kentucky, pursuing one mission to improve the health of our communities, emphasizing people who are poor and underserved. Together, our passion is to make lives better and make healthcare easier. The regions Mercy Health serves include Cincinnati, Kentucky, Lima, Lorain, Springfield, Toledo, and Youngstown. Additionally, we have a partnership with Summa Health in Akron, Ohio, providing them with use of our instance of the Epic EMR. Some quick facts and stats about Mercy Health include that we have nearly 500 places to receive care, 23 hospitals, 7 senior health and housing facilities, and 7 home health agencies. We employ over 33,500 people and have over 1,300 employed providers. Mercy Health provides $10.1 billion per year in economic impact in the state of Ohio. In 2017, we had 6.8 million patient encounters. We maintained 6.8 billion total assets, and we had 4.7 billion in net operating revenue. Our mission in action. Mercy Health is investing over $1 million a day. In 2017, Mercy Health invested $384 million to benefit the communities where we provide care, and most of it targeted to help people who are poor and underserved. $267 million of that benefited the poor and underserved, while $80 million went to benefit the broader community. And now for an overview of CarePath, which is Mercy Health's branding of the Epic EMR. CarePath is a comprehensive, safety-oriented, patient-centered clinical information system utilizing Epic information technology. The PATH in CarePath stands for Patient-Centered Access to Team-Based Healthcare. Our informatics governance structure at Mercy Health is such that build is governed by the clinically led CarePath informatics committees. Recommendations for system changes come from the end users and are vetted with the respective system committees. Inpatient informatics is co-chaired by 2 providers, both medical and surgical, and 2 nurse leaders. Ambulatory informatics is co-chaired by both providers and a nurse. Currently, we have 15 certified physician builders, including 2 from our Connect partner, and 3 we are working to certify. Some of the recent accolades Mercy Health has received include: we are a 2018 HIMSS Davies Award recipient. We have HIMSS Stage 7 certifications at all Mercy ambulatory practices and at 7 acute care facilities. We are a Most Wired Advanced winner. We've received a system uptime recognition from Epic, as well as the Epic Summa Cum Laude for our honor roll. Now for the flowsheet charging for bedside procedures project that I was a part of. We'll start with some background. I'll give a quick primer on what I mean by bedside procedures. These are inpatient services that fall outside the CMS definition of routine services that are included within the inpatient room and board rate. We'll see a full list further on in the presentation, but some examples include lumbar puncture, chest tube insertion, and bone marrow biopsy. Historically, it's been a bit ambiguous whether or not organizations could charge for bedside procedures on inpatients, or whether that was considered quote-unquote double dipping with the inpatient room and board rate. However, upon review of CMS guidelines, specifically in the provider reimbursement manual, our revenue cycle operations team found that procedures need to be charged consistently on inpatients and outpatients, such that any service we were charging separately on outpatients, we also needed to be charging separately on inpatients. So in late 2016, early 2017, it became a revenue cycle operations initiative to push for charging for bedside procedures in order to comply with CMS guidelines. Next, I'm going to talk through some of the problems we faced when we first implemented bedside procedure charging on our nursing units. Our initial approach had drawbacks from both a workflow design and a revenue capture perspective. And first, I'm going to talk through the workflow design issues. When Mercy first implemented bedside procedure charges, we added them to a charge capture navigator, which is its own section within the chart, separate from the flow sheets activity where our clinicians were doing the majority of their documentation. We chose to put the charges in charge capture because this is where all of the other nursing unit charges were available, so it was a pretty standard practice for our nursing unit in terms of charge capture workflow. However, we soon began to receive feedback from nursing leadership that their staff were really struggling to enter these charges. Firstly, there were quite a few net new charges that had been added, and the nurses had not internalized what procedures were chargeable and which ones were not. And secondly, they found that navigating from the flow sheets activity to the charge capture navigator every time they needed to enter a charge was a cumbersome workflow. Even though they knew that the bedside procedure charges had been added to charge capture, each time that they wanted to charge for one, they had to consider whether the procedure they had done was chargeable, exit the flow sheet activity, open up the charge capture navigator, identify the charge for the procedure they had just performed, and then enter that charge. For a nurse on a busy inpatient unit whose main focus was providing patient care, the workflow just wasn't practical, and it was a dissatisfier for our clinical partners. The other problem that we had was missed revenue. Our revenue cycle operations felt that the bedside procedure charge volume did not align with expectations based on our organization's size and patient population. They were concerned not only that we were leaving revenue on the table, but also that we were missing opportunities to more accurately report productivity on our nursing units and more accurately reflect the cost of care for each of our patients. Both revenue cycle leadership and clinical leadership recognize the need for a more streamlined and more functional workflow. While providing amazing patient care will always be the priority for our nurses, effectively capturing revenue is what enables Mercy Health to fulfill its mission to improve the health of our communities with emphasis on the poor and underserved. On the CarePath team, we continuously look for opportunities to improve efficiency for our clinicians. On the whole, we're asking nurses to do more and more and document more and more. So anything that we can do to reduce the time it takes to complete tasks is an improvement that we want to do. Our role on the IT team is to do what we can to make our clinicians' lives easier and enable them to use our EMR efficiently and accurately so they can focus on their priority of providing patient care. We thought that we could streamline the workflow in charge capture so that the clinicians could capture the missed revenue while still managing to prioritize patient care. So we had a hypothesis that if we embed bedside procedure charge capture workflow within the flowsheets activity where clinicians were already spending most of their documentation time, users would be more likely to enter charges. Developing a flowsheet charging workflow was a collaboration between revenue cycle operations and CarePath orders, ClinDoc, and hospital billing teams. Revenue cycle operations provided a list of procedures and their associated charge codes, and CarePath conceived the system design. By placing the charges right where nurses are documenting, we provide an improvement in throughput, decreasing the total number of clicks it takes to capture revenue. With this streamlined workflow, documentation and charge capture can happen virtually at the same time, so nurses can spend less time in the EMR and more time with their patients or doing the other things that they need to do. We implemented flowsheet road charging in 2 phases. Phase 1 went live in July 2017 and included 22 of the most commonly performed bedside procedure charges, and these were ones that were less complex to create. Phase 2 went live in September 2017 and introduced an additional 12 flowsheet charge rows, and these were a bit more complex. To determine where to integrate the charges into flowsheets, the CarePath ClinDoc team leveraged nursing leadership to use their expertise and familiarity with the documentation practices to guide where to place each chargeable row. They scheduled meetings for several weeks to ask questions and request feedback as the system builds progressed. One of the key features of flowsheet road charging is that the documentation rows are shared across the organization. All nursing units have access to the same rows, and this design allows CarePath to maintain standardized build within the Mercy Health Ministry, and this makes maintenance easier as we are maintaining the same build for all nursing units at all of our 23 facilities. And it also makes training easier because we're teaching the same workflows to nursing end users all across our ministry. Having standard build also provided our revenue cycle operations the opportunity to standardize their charge master so that we're charging the same charge codes for bedside procedures at each facility. While we did incorporate over 30 charges into flowsheet rows, we also left some on the charge capture navigator. What remained in this section were charges that, by nature, didn't make sense for discrete documentation. However, we still found an opportunity to optimize charge capture by reorganizing it into 4 standard folders that are shared across the ministry, and we'll take a look at those later on in the presentation. Our goal with the charge capture section was to make it more intuitive to use in order to help eliminate any missed revenue. These are the 22 procedures that were included in the Phase 1 flowsheet road charging implementation in July 2017. We were able to add these to the first phase because they were a little less complex to create and more straightforward to incorporate into the flowsheet rows. They just require less time to receive feedback from nursing leadership on where to place them. These are the 12 procedures that were included in Phase 2 in September 2017. These were more complex and they required more collaboration with nursing partners to guide where to place the charges within the flowsheets activities. This screenshot has examples of chargeable flowsheet rows in our specimen collection flowsheet. The fact that a row is chargeable is indicated by the $sign preceding the name of the row so that clinicians can easily discern which procedures are chargeable and which are not. This screenshot just shows how we embedded charge capture within the flowsheets navigator where nurses were already spending most of their clinical documentation time. For the CarePath team, anything we can do to reduce the total amount of time it takes for clinicians to do their jobs helps fulfill one of our promises as an organization to make healthcare easier. Making our EMR easier on our nurses helps keep them happy and ultimately helps Mercy Health retain strong clinicians to provide the amazing patient care we want to be known for. This next screenshot shows charges in a procedural charges section on the daily cares and safety tab. This section was a net new addition to the flow sheets, and items grouped here in this section did not fit neatly into existing documentation areas. This one is a good example of the collaboration between CarePath and our partners in nursing, because at first we didn't know where to put these charges because they weren't a good fit for other sections. And ultimately we grouped them on the Daily Cares and Safety tab at the suggestion of the nurses with whom we collaborated on this project. The reasoning was that they spent a significant amount of time documenting in this section already, and so adding these charges here made them very accessible. As I mentioned before, some charges available on nursing units do not make sense to be captured via discrete documentation in flowsheet rows, and these remain in the charge capture navigator. We didn't just leave them here. We reorganized charge capture into 4 standard sections used across our ministry: bedside procedures, infusion and injection, chemotherapy, and miscellaneous. First 3 sections are pretty self-explanatory. Bedside procedures folder houses additional bedside procedures that fall outside of the scope of what we're charging in flow sheets. Infusion and injection and chemotherapy houses charges related to infusion and injections and chemotherapy, you guessed it. And the miscellaneous folder is where we put anything that doesn't fit into one of the standard sections. Charges in this folder often are not good candidates for standardization because they're specific to certain departments. For example, we would put a car seat study in a nursery department, or a wound debridement charge on a burn unit in the miscellaneous folder. Again, our goal with having standard folders was to make Charge Capture Navigator more intuitive to use, grouping like charges together to make them easier to find, and creating consistency across all of our nursing units. Over the next couple of slides, we'll walk through the timeline of this project. Starting in October 2016, this is when we first added bedside procedure charges to Charge Capture. December 2016 is when we received feedback from nursing units that they were struggling with the workflow. January 2017, our Revenue Cycle Governance and Inpatient Clinical Informatics Committee decided they wanted to pursue flowsheet row charging for bedside procedures. And in March 2017, we had our initial meeting with the project team. In May of 2017, we defined the scope of bedside procedures to be incorporated into flowsheet rows. In June 2017, we completed flowsheet and charge capture build and testing, and also developed a tip sheet for end users. In July 2017, we had our phase 1 go live, followed by September 2017 when we had our phase 2 go live. Because the change in workflow was relatively simple, we did not use formal training in a classroom setting. Instead, we created a tip sheet that outlined how to access each chargeable flowsheet row and posted it on what we call a learning home dashboard, which is a tip sheet repository located within the EMR. Additionally, we communicated this workflow change in multiple forums. We included it in a CarePath e-newsletter published weekly with the news of system updates. We communicated this through site specialists, which are our boots-on-the-ground clinical IT liaisons located at each site. And we also communicated this at nursing leadership meetings and revenue cycle operations meetings. We monitor the success of flowsheet charging with a couple of different types of reports. Firstly, we have our revenue reports, and these compare the quantity and dollar amount of bedside procedure charges each month to a baseline period, which was the month preceding the phase 1 go live. Secondly, we're developing a clarity quote-unquote mismatch report called Nursing Procedures Without Associated Charges that compares pieces of nursing documentation against the charges on the hospital account, returns cases where a charge may have been missed. When nurses document, they often have to enter a Y or an N for yes or no on the chargeable row, and the report catches when they enter one piece of the documentation but don't, for example, click the Y. This report's still being refined and it's not yet available on every charge. Currently, we're running it on blood specimen draws, urinary catheter insertions, and bladder scans. Next, we'll take a look at what this mismatch report looks like. On the report, we see the patient's room number, their contact serial number, which is linked with their visit in the EMR. We have the date and time of the documentation, as well as the name of the clinician who entered the charge. We have a link to the patient's chart and the nursing unit that the patient was on. Flowsheet road charging is governed jointly by the Revenue Cycle Governance and Inpatient Clinical Informatics Committees at Mercy Health. These committees work together to propose what service lines become candidates for flowsheet road charging, prioritize our implementation timelines, and define the scope of procedures to be included. And now a look at our return on investment. From the baseline period, which was mid-June through mid-July 2017, we had 978 bedside procedure charges captured and $379,000 in revenue. After 1 month, we saw nearly a 200% increase in gross revenue and over a 200% increase in the number of charges captured. When you look at the monthly average statistics from 1 year post-implementation, these results have remained consistent month after month, even increasing a bit from that first month. Next, we're going to take a look at graphs showing our return on investment across our ministry. To orient you to the graph, the green bar shows the dollar amount of charges and the blue line shows the number of charges. We'll be looking at Mercy Health facilities using CarePath, Resolute Hospital Billing as their billing system. And the first data point is going to be the baseline period, which was mid-June through mid-July of 2017. And the data runs for 1 year post-implementation, which was mid-June through mid-July 2018. This first graph is an overview of all of our markets, and we'll take a closer look at each one. But you'll notice in each that the trend is an increase in both charge volume and revenue at each facility. First, we'll take a closer look at the Lourdes market. Lourdes market is comprised of a single facility in Paducah, Kentucky. From the graph, you can see that the dollar amount and quantity of charges sharply increased in the first quarter after go live, and this has continued steadily upwards since then. Next is our St. Rita's market, another single facility market located in Lima, Ohio. Again, you can see a jump in the dollar amount and quantity in the first quarter post-implementation that have, aside from some seasonal fluctuation in the winter months consistent with flu season, remain consistently elevated since go live. Next is our Lorain market. This is comprised of 2 facilities, one in Lorain, Ohio, and one in Allen, Ohio. Allen's on the left half of the graph. It's a smaller facility with a lower charge volume overall, so the graph doesn't look as dramatic as at some of the larger facilities. So you can still see that there's an increase in the first quarter post-implementation and that this has remained consistent through the last month. At Lorain, on the right half of the graph, you can see a sharp increase in the first month post-implementation, and that has also remained relatively steady since then. Next is our Toledo metro market. This is 3 facilities located in Toledo, Ohio. St. Anne on the left side of the graph has stayed relatively consistent in the number of charges, but the dollar value has increased, suggesting that their volumes may have shifted from lower cost to higher cost procedures. St. Charles and Vincent both show a steady increase in the number and dollar amount of charges since the project go live. Next is our Toledo rural market with 3 facilities in rural areas outside of Toledo, Ohio. These are all smaller facilities with lower volumes overall. Defiance on the left side of the graph was slow to take off. As you can see, there was an initial decline in the number of charges, but when you compare the first bar and blue dot to the last, you can see that the numbers are still generally increasing. Tiffin and Willard on the right thirds of the graph tell a more familiar story, an increase in the first quarter post-implementation that has either remained consistent with some seasonal fluctuation. This is our final graph, and for each facility, it compares year to year, the baseline period of mid-June through mid-July 2017 to 1 month post-implementation, mid-June through mid-July 2018. Facility by facility, we see that we are capturing more charges and more gross revenue at each site. All of this suggests that our hypothesis was correct. If we meet clinicians where they are, embed charging within their clinical documentation, and make the process more intuitive for them, they'll capture more charges and will help us meet our goals as an organization. Our main focus is always going to be providing great patient care, but capturing this additional revenue enables us to keep our lights on, provide that great patient care, and give back to our communities in ways that help us fulfill the mission of our organization. While the numbers are impressive, they don't tell the whole story. Not only has this project been a win in terms of gross revenue increase, but maybe more importantly, it's been a win for patient care. If nurses can spend less time on documentation, they'll have more time to spend with their patients, providing the amazing patient care that we expect at Mercy Health. Testament to this came from our Chief Nursing Executive in our northern markets, Jody Paul. And at Flowsheet Charging, Jody says, this has been a great opportunity to automate processes for our nurses so they can spend more time at the bedside caring for the needs of patients. Not only were we able to make the process more efficient for our nurses, but we positively impacted the revenue for our ministry. Next, we'll take a look at the cost for this project. There was no capital expense. The only cost was manpower and the labor hours to do the analysis and system build. In the second phase implementation, the total labor hours decreased, suggesting that as we continue to roll out flowsheet charging to other service lines, we'll be able to do so more efficiently and at lower cost, improving our return on investment as we scale this functionality out. Next steps and lessons learned. Currently, CarePath is collaborating with revenue cycle operations to implement flowsheet charging for new service lines. All of our respiratory therapy departments across Mercy will go live with flowsheet charging on September 22nd, 2018. Our outpatient therapy, the PT, OT, and speech departments have expressed interest, but the date is still to be determined on that. We're also working to expand the scope of the mismatch report to identify mischarging opportunities. Throughout the process, we've learned that communication and education are vital to the success of the new workflow. For future implementations, we will emphasize communication prior to go live. Overall, our take on this project was that flowsheet charging was a unique opportunity for our clinical and revenue cycle teams to work together to achieve a common goal. Thank you.
Well, thank you, Jessica, for that great presentation. I want to remind folks where to go find other presentations like this one and information on how to apply for the Davies Award. That information can be found at the HIMSS Davies Award website at hims.org/Davies. Again, thank you so much for joining us today, and thank you for the great presentation.